I will try and very high level briefly introduce you to the technology so you have a better understanding of the speakers after me who will more talk about the application in the actual field of our technology. Okay, so we are a new company, and basically we are set up to really make a difference. You won't see, I would say, me-too products from us. We really want to make new technologies that makes the difference for the critical patients. Those patients who really benefit from a faster diagnosis and a faster, correct and appropriate therapy. And what we have done is made a fully automated system, because that's what's required in laboratories nowadays, which hosts all the technology we use to generate a result. And our first platform is basically designed to give you an MIC as fast as possible. We use different steps in between, but the main purpose is giving you the MIC of the organisms which are affecting the patient so you can treat appropriately. A bit up. Is this better? Okay, thank you very much. Sorry. So what we do in the system is, first, let's say, application is a positive blood culture, which is a crappy sample, to be honest. I mean, there's a lot of debris in a positive blood culture bottle. Dead blood cells, dead bacteria. We want to clean it up. We want to immobilize those bacteria because we want to analyze them. First and foremost, like we said, we use automated FISH to ID most of the organisms, the most prevalent ones. We do know we need the ID because we have to know which antibiotics to dispose them against so we can do the MIC testing. Of course, when we know the ID, we'll report it out, but the main thing in the end is give you the correct MIC as fast as possible. And that we do with digital microscopy, and I'll explain that later. The big difference between our technology and, sorry for not seeing anything here, I'm not faking you. These are nicely growing cells. The resolution on the screen for a change is better than this one. You will see cells dying here. But the big difference in our approach of setting the MIC is that we don't look at the average effect of a large population of bacteria. No, we analyze individual bacteria. And to make a single MIC determination, we analyze anywhere between 500 and 1500 bacteria developing in the presence of antibiotics. So what we do, we follow those bacteria over a period of 4.5 hours. Every 10 minutes, we make an image of every single CFU we find in the sample, and we revisit every single CFU every 10 minutes for 4.5 hours. And you get a kind of a, let's say, video time-lapse image of it. We as humans, we can see things happening in computer can't. So then we have to, let's say, transcribe these images into measurable units. And what we have done is that we have designed about 13 different morphokinetic parameters which describe the change in shape or the kinetics of bacteria over those 4.5 hours. Now here, for instance, you see clone intensity, let's say amount of clones developing from that sample in the 4.5 hours. When we have a growth control where we have the bacteria growing without presence of antibiotics, and we expose them to a certain critical concentration, to a single concentration. And depending on their resistance profile, they will develop differently. And we analyze these developments. This is just one of the parameters. As I said, we use about 13 of them to a huge database of known strains and antibiotic and MICs. You could compare it to that extent a little bit what's happening with the MALDI-TOF, where you have all these profiles for the identification. We have generated in our database profiles for MICs. And the system has been trained to give the MICs as given by the broth microdilution as a standard method. So that's what we use to train our system. Today, the first sample we have is a positive blood culture sample. That's on the market, CE marked, FDA approved. At the moment, we are in the end development of respiratory samples for ETA and BALS, for HAP and VAP. That's what we're currently working on. And next is soft tissue and urine. Like I showed, you saw this complete instrument. The complete instrument comes with a single kit. So the hands-on time is really less than 2 minutes. There's one button, like in an espresso machine. It's the only thing you do. There's a cartridge, a sample, and a cassette in which we measure our tests. Within 7 hours, start to finish, you have your MIC. And along the way, once we know the ID, we report it out as well. So within an hour and a half, you know the ID of the organism which is present in the blood center, positive blood culture bottle. Okay, as I said, totally automated. It's really 2 minutes hands-on time. The next thing we are doing, same platform, same systems, same reagents, kind of, going to validate bulks and ETAs. Here, we need a little off-life sample prep, because to report out a correct MIC, you need organisms in the exponential growth phase. And you can imagine, in a blood culture bottle, that's the case when it flags positive. They are growing exponentially. However, in other, let's say, normally sterile body fluids, or like a respiratory sample, they are not happy campers, and they're not growing in the exponential growth phase. So we have a short offline pre-incubation to bring that in the growth phase, and then same thing, put it in the system, press the button, and everything is done automatically, and within 7 hours you have the result. But it will be, including, let's say, the 3 hours for your sample prep, a 10-hour result. Basically, as these samples come in the lab during the day, you have a next morning result, whatever comes. The next thing, like I said, we report out an MIC, but we have a lot more information which can be used for the patient. And that's, an avenue to explore in the future for really critical patients, that we also can give minimal bactericidal concentrations, we can give time kill curves, or population analysis. And a good example of that is that we can also test for H visa. So this is a poster we presented at the ECMID from Ryback from Detroit. And here in the first pilot, we had very good results identifying H visa. Totally automated within the same 7 hours, as explained, for the normal samples.
So our kit in our hospital, we use the BD Bactec FX. We use the gram stain, and then we have been routinely using QuickFish, which I'll show you, to identify organisms from blood cultures. We can then use the Bruker sepsityper on the moldy TOF to identify other organisms rapidly, and then we do direct sensitivities for the gram negatives, and we use the BD Phoenix for the complete sensitivity pattern over the next day. And so it looks something like this. We have the gram stain here. QuickFish, which I'll show you, takes about 20 minutes, and so we phone out that with the gram stain to the clinical teams. When we have a positive result from the QuickFish, we can use the sepsityper for the gram negatives that aren't on the QuickFish panel. We have some direct sensitivities after about 24 hours, and then another 24 hours for the final sensitivity result. Thanks. And so we looked at our QuickFish. This is our poster from ECMID 2016. So QuickFish is a peptide nucleic acid fluorescent in situ hybridization PNA fish assay. And these target several different organisms. Based on the gram stain, you choose the QuickFish kit to use. Takes 20 minutes, so we call that to the teams. And we looked at about 1 year's worth of data. Here's the process. It's just done on a slide, adding a drop from the blood culture, the QuickFish kit, and then having a look under the microscope at the color. And the results are something like this. So if it's gram-positive cocci in clusters, within 20 minutes we know if it's a Staph aureus, and that would almost always be MSSA. We hardly ever see MRSA, so we know what to treat the patient with. Red is coagulase-negative staphylococci, and we could see a mixture or no color, which would be other funny things like micrococcus that would be contaminants. Gram-positive cocci in chains, we can tell in 20 minutes if it's E. faecalis or other Enterococcus species, so mostly E. faecium, or a mixture or no color, which would be other things like viridans, streptococci, and pneumococcus, all sensitive to penicillin. And the gram-negative rods, we can tell if it's E. coli, Klebsiella, or Pseudomonas, or some mixture, or if there's no color, it will be another gram-negative rod like Proteus or Enterobacter. So that's how it works, and it performs very well for the gram-positive. So Staph aureus, we just missed one, very accurate for the coagulase-negative staphylococci, perfect for the enterococcal species and the other streps. and quite good for E. coli, Klebsiella, and Pseudomonas, missing 1 or 2 cases over these few hundred of cases here, and usually the ones with no color were correct as well, but not always. So very good performance for gram-positives, slightly less good for gram-negatives, which we'll expand upon. And so when we can try and extrapolate this, if we have the FISH result, do we know what to treat the patient with? And for the gram-positives, usually yes. If it's Staph aureus, we can give flucloxacillin. If it's Enterococcus, we know if it's E. faecalis, we treat with amoxicillin. If not, ticaplanin, and we know our VRE rate. Usually we know a patient is VRE colonized, but there's probably less crucial knowing it's VRE and changing as rapidly as in the gram-negative infection cases. And where there's no color, we can usually guess it's either a contaminant or a Streptococcus sensitive to benzoyl penicillin. So we can infer a lot about the treatment from the quick FISH results for the gram-positives, less so from the gram-negatives because their resistance patterns are so hard to predict. The E. coli, so our ESBL or AMP-C rate is about 12%, 15%, or meropenem resistance about 12% in Pseudomonas. So even with the quick FISH from the gram-negatives, it really doesn't help us that much in deciding what to treat the patient with, which is the gap in our diagnostic pathway. So again, the conclusions were we can conclude what to treat the gram-positives with, but we struggle with the gram-negatives. And so that's where we come on to something a bit more sophisticated, which is the Pheno system we've heard about. And we've done an evaluation study with colleagues at Imperial College to look at some cultures, which I'll just present the abstract. So this will be presented at ID Week, but the content of the abstract we've already submitted. So the Pheno uses FISH, so similar to I've shown you the nice pretty colored pictures, that happens inside the Pheno machine. It's got a few more targets, so it can name a few more organisms, and then uses the culture characteristics to give an MIC. So we wanted to see how accurate this was across a range of test organisms. The antibiotic panel is across the top here, if you can read sideways. And this is useful for most of our antibiotics that we use, although of note for us in the UK, the panel at the moment doesn't contain amoxicillin, which is quite good when we focus down the antibiotic use. If we want to target and use narrow spectrum, we like to narrow down to amoxicillin. Similarly, coamoxiclav and temacillin we use a lot of at the role-free, particularly in our renal population. So having these on the panel would really help us narrowing down and optimizing antibiotic therapy. And the gram-negative targets, you can see there's more than just E. coli, Klebsiella, there's Enterobacter proteus, so you get more information about the organism name and then the antibiotic sensitivities. So we chose 15 gram-negative isolates. Here we're just focusing on the gram-negatives because that's where we think this will be most useful. And we picked them with a range of different resistance patterns, a few resistance genes, and then we tested them repeatedly at our site and in parallel at the Imperial site to see what the variability was. And we found the results were good. So the identification was good, 9 out of 10 organisms, and then the ones that weren't on the panel were also correctly not identified, but identified that there was bacteria present. And the tricky one was a Citrobacter, which was correctly identified when we retested it. And the antibiotic results were quite reliable and reproducible. So high level of agreement in the 90% within site when we repeated them within site, and then across the sites they were reproducible as well. So this was quite satisfying that it was a reliable system to give us rapid antibiotic results for the sort of organisms that trouble us with their drug resistance patterns. So this was good news, and then the next question is how do we use this in practice, and what's the potential impact? So we did a little thought experiment about this. So we looked at 32 of our cases of gram-negative bloodstream infection and tried to imagine if we had the sensitivity results more quickly, how would that help us? And what we found was usually our empirical treatment is effective. So we start patients on coamoxiclav or tazocin with often gentamicin or amikacin. So we start broad spectrum, as we're told, to start smart. And almost always that covers the pathogen. So it's almost always effective empirical therapy. So there's little scope for something like the Pheno to add to that effectiveness. In fact, it only would have added in one case, but only if it had, without having those additional antibiotics, amoxicillin, Coamox, or temacillin. If we had those antibiotics on the panel, it might have helped us a bit with therapy, knowing Coamox could have resistance, for example, very rapidly, then we could have altered treatment. However, sorry, just to go back to the second group over on this stage, on this side, is where we thought there'd be more impact, would be optimizing therapy, where we could narrow down the antibiotic spectrum to target the organism if we knew sensitivities more quickly, and there was a bigger potential impact there. So it would have helped in about 40% of cases with the current panel, but if amoxicillin and augmentin were added, we thought maybe up to 60% of cases we could have targeted therapy, with the results after the 7 hours or so. And if temacillin was included, because we used a lot of that, then another 20% up to 80% we could have optimized sooner. So that's where we really saw the potential impact of this, was not the gram-positive organisms, the gram-negative organisms, and not so much the empirical treatment, but the targeted treatment that we're trying to optimize. And so potentially the biggest impact would be where we had high-risk patients. So for us, that's our intensive care unit, our renal, liver, and hematology oncology units, where maybe effective antibiotics or because they're high antibiotic users, narrowing spectrum might have a better impact on the ecology of the unit. So we think the next step is probably to look at these groups, so gram-negative infections in the high-risk units. And we think the impact could be increased if there were these additional antibiotics on the panel. And then the bottom line there is we'd next need to look at the cost effectiveness. So these are probably the highest cost units in terms of the high cost of infection or inappropriate treatment. And maybe, again, we think the potential impact would be greatest in those units. And then finally, where we imagine this might shorten our gram-negative. So we'll probably stick to quick-fish for the gram-positives. We get the ID, we know what to treat the patient with. And the gram-negatives maybe phenosystem coming in here. So at about this point, we might then have a good idea about appropriate antibiotic therapy or targeted antibiotic therapy rather than further down the line here, although we'd probably keep going with our full panel, at least for the time being. And recent paper from another group have looked at the same thing, the gram-negative organisms in their service. I think this was in Germany, in Tübingen, and their results showed the results were very accurate. So the sensitivity testing was very accurate, but they haven't gone on to measure the impact of that. So a lot of ours would probably be overthinking the problem at the Royal Free, but we're about to hear from Nikki where they've really applied this in the clinical setting to their patients. So thank you, and I'll hand over now.
So our approach at Hampshire Hospitals was slightly different, but I'd like to start off by, we're actually using the Accelerate Pheno with some of our patients and have been doing it for a number of months. So I'd like to start off with a case study of a patient I treated at the end of May, and then tell you what we've done and what our next steps are. Okay, so this is a lady who I saw on a Friday morning on our intensive care unit, 55-year-old lady. She'd had extensive surgery for pseudomyxoma, which is a very rare abdominal tumour. The operations normally take about 10 hours, and they'd taken out her gut, her gallbladder, uterus, and her tubes. And she'd also had intraoperative chemotherapy at high temperature. And she was then sent to ITU, and the day later she developed neutropenic sepsis. Blood cultures were taken at 9:30 in the morning, and we started her on our standard protocol, which was Coamox and Gent. Quite quickly for us, the blood cultures were actually on the machine by 10 o'clock. That's because this lady was in a hospital where the microbiology lab is, so it just had to come downstairs. At 10 o'clock in the evening, it signaled positive, but like a lot of microbiology labs, we only run an on-call service overnight, so there was no biomedical scientist in the lab to pick it up. So it was picked up when they came in, and the next morning, and the gram stain showed a gram-negative rod. So we decided on our bench round at 9:30 that this was a sample that we would put through the Pheno ID, and by 11:30 that morning, it had given us an ID of E. coli. And then by 4:45, it had told us that it was an ESBL positive organism. sensitive only to the antibiotics up there. So that meant before 5 o'clock I could change her antibiotics, and we put her onto meropenem, which was far more effective treatment for somebody with an ESBL-producing organism, and we also made sure that she was appropriately isolated on our ITU. Our current standard of care for blood cultures is that once they're positive, we do a gram stain, we then subculture them, and once we've got a growth, we put it on the Vitek for ID and sensitivity, but we also still do old-fashioned diffusion sensitivity testing. Next one. Anyway, the patient improved within 24 hours. I'll just put up some of her markers there. So you can see her CRP got right up to 638, but once she was on the meropenem, it started to come down. Her white cell count picked up from being neutropenic, and her procalcitonin started to drop from a high of 8.7. And she was out of ITU by the end of the 4th of June. So what we had been doing with the Accelerate Pheno is that we thought about how we would run it in our department. We thought that we would probably have, again, we were concentrating mainly on gram negatives, but we did do some gram positives at the beginning, so probably 2 to 3 patients would go through per day, and we have 2 Accelerate Pheno systems in our microbiology lab. And when we did our microbiology bench round in the morning, the consultants would talk to the BMSs, and we would decide which samples would be appropriate to go through, and we designed an algorithm. During the study of the evaluation, we only ran this system between 9 a.m. and 8 p.m., so it wasn't done out of hours. And this just shows mainly that for gram-positive cocci, gram-negative rods, and yeasts, if it fit with the patient's needs, so if they were on the intensive care unit or our HDU, or they were from the emergency department or the acute assessment unit, or if it's another patient that we thought was sick, so a neutropenic hematology patient, we would put them through the Pheno system, and otherwise we would just culture them as normal. So we trained a number of our BMSs to use the system, which they found quite straightforward. All the consultants in the department were given documentation on what to do if a positive came up and how to choose, and we designed a pro forma to have a look to see how it would have affected standard care. And also, before we ran it, we did a preliminary validation of the Pheno system, so we analysed both the company data, the validation data. We gave some mixed samples that we spiked with, and we spiked with some single organisms, and we ran it in parallel with some clinical samples just to make sure we were happy that the system worked. So what we were looking at, well, what's this going to do for our patients? Is it going to allow us to optimize antibiotic therapy? Is it going to facilitate IV to oral switch? Is it going to reduce our antibiotic use? Bearing in mind the sepsis sequence that were present last year and the ones going ahead for the next 2 years, is it going to reduce broad spectrum antibiotic use? And will it help us with infection prevention and control? And what bit is going to drive it? Because we didn't have a quick fish, so would knowing what the ID was within an hour and a half help change management, or was it the sensitivity, or was it both? The results, when they come out, the system are very easy to read, so you get a preliminary result after an hour and a half normally, and it tells you can't see very clearly what the organism is. And then after 6 hours, you get a result where it gives the MIC, a raw, sensitive, intermediate, or resistance, and then some of them have an algorithm within the system, and then it interprets it to UCAST, or as to whether it's sensitive or resistant. So we used blood cultures from 54 patients, where the samples produced sensitivity of 91% and specificity of 100%. So not all patients were then used for sensitivity testing, and I'll show why, but those that we did gave essential agreement, that's where it's the same MIC of 97%, and categorical agreement of sensitive or resistant of 97%. I don't know if you can see this clearly here, but most of the identifications matched with the Vitek for our gram negatives. We had one E. coli where the cell count was not high enough in the Accelerate system for it to identify it. So it labelled it as an off-panel organism. And another one there, the background was too high, so it didn't identify the E. coli. And this was our gram-positive, so again, it picked them up all very well, picked up a mixed growth. I remember the Euphicalis and Klebsiella one, it was one we found early on, and actually the gram film only showed the gram-negative, so without the accelerate, we wouldn't have known that Enterococcus was there until 24 hours later when we picked up a strep on culture. There were a couple of bacteria, I feel like animals, that were off-panel, and as we're using it more frequently, more regularly, we are noticing, we had a run of patients, returning travellers from Basingstoke they'd come back to Basingstoke from abroad, and we had 3 patients with typhoid within a month, and unfortunately, the pheno doesn't identify typhoid, but it did tell us it wasn't an E. coli or a Klebsiella, so it helped indirectly thought that it might be a salmonella. This is just showing that the sensitivities actually was very good correlation, it's already been mentioned. And the big difference was that the turnaround time, so for us the ID, I said, was in an hour and a half, and the sensitivity testing came out within 6.5 hours, compared to our standard of care, which was sort of 44 hours for ID, and sort of 24 or 44 for sensitivity and MIC. So a significant difference of 24 hours at least. So when we looked at what this did for our patients, we found that we facilitated 14 treatment optimizations, 6 IV to oral switches, 12 reduction in multi-antibiotic use, and 5 early interventions for infection control. And also in 6 patients we could reduce the broad-spectrum antibiotics. And I've got a couple of the cases up here. So there are quite a lot on here. The first one was a patient that we actually found an AMP-C-producing serratia in. The patient was currently on tazocin and gentamicin. So given the fact that tazocin won't be effective, we switched them to meropenem. And we had a patient who was seen in ED and sent home just on oral Fluclox because they thought that they had a Staph aureus infection, a skin infection, but the blood culture came up positive, and by the time we'd call the team, we knew it was a Pseudomonas, so when they came back in, they were reassessed and started on anti-Pseudomonal treatment. There's another patient here who was initially started on Gent and Tazocin, and we were able to switch it down from Pip-Taz to Coamoxiclav and stop the Gent, so we could narrow the spectrum down. There was one where we had a patient who was, we had a patient who was a returning traveller, and they were at high risk of CPE, and then they became unwell and they had a gram-negative in their bloodstream, so we were really worried it might be a CPE. And the pheno allowed us to identify it as a fully sensitive E. coli, so it wasn't, so we could relax and make sure our ITU wasn't closed down. So the feedback from the BMSs in the lab is that the training was straightforward. The system is genuinely very easy to use. You just put a few drops into the little bottle and put it in the machine, turn it on and walk away. So they really like that. The QC procedure was straightforward but could take a bit of time. There were a couple of run failures early on, but the team from Accelerate were very good and the support was great. And they had remote access into the system, so they could fix it remotely and then have us on our way. So we too found that it was most useful with gram-negatives, and because with our gram-positives we have internal tests that you can do very quickly, so if it looks like a staph on the gram film we would do a direct Binex which would tell us it's a Staph aureus or not, and if it was a strep we would do a dry spot potentially to see if it was a pneumococcus, or we might do a direct group if it looked like it was beta hemolytic. So there were cheaper ways of identifying the gram-positives without using the pheno. But it was very useful for gram-negatives. It did support us in starting SMART and focusing. So again, there weren't many occasions where we had to escalate treatment, but there were quite a lot where we de-escalated it. It allowed us to introduce infection control measures more quickly. We were continuing to use it as we tackle with the new sepsis sequence for 17 to 19. As been mentioned, currently the panel is designed for the US rather than the UK, and we really miss not having amoxicillin or co-amoxiclav on that panel because we use those antibiotics quite a lot. So the problem for us at the moment is how do we elucidate the financial benefit? It is an expensive test to do in the laboratory, but if you look at the overall patient pathway and the amount of money that you might save because reduced time in ITU or reducing the spectrum of fewer broad-spectrum antibiotics, more narrow-spectrum antibiotics, isolating patients more quickly to prevent spread of infections. So we're working quite hard on that now so that I can take a business case to board to get approval in these difficult financial times to have it put in the department. We've now moved on to a second phase study. So we now have a system where we, as consultants on out of hours, can get the ID and the sensitivity. So the BMS just puts it into, starts the machine going, and they can do that any time up to 8 p.m. when they leave. I will then get an email telling me there's one on the system. An hour and a half later, another email telling me what the ID is, and then 4.5 hours later telling me what the sensitivities are. So I can genuinely start to change antibiotic treatment overnight. And we're in the middle of doing that now, and it's working quite well. The other thing that we want to look at is, like a lot of microbiology labs now, we're a trust with a number of hospitals, and only one hospital has the lab in. So the problem is that for patients who are bacteremic on the other side, there's quite a long delay from blood culture bottles coming from the other site to where the lab is. So we're hoping to put a pheno system in the blood science lab on that other site because it is so easy to use that our biochemists and hematologists are happy to consider inoculating it into the machine. As consultants, we get remote access for the result. So our only thing that we're looking at the moment is having someone to remotely read the gram stain, because the BMSs are happy to do a gram stain, but because they're hematologists and biochemists, they don't want to be able to read it. So we want someone remotely to read it. So we're hoping to look at that in the near future. So obviously this has all been done by my team. I just wanted to give acknowledgements, and that's where we are.